So what you need to do is that you need to give a meal at least half an hour. You need to give a meal, and the PPI has to be given half an hour before the meal, so that both will match up. As the food goes down and activates the PPI pumps, by that time the medicine taken half an hour before will go up, rise in the bloodstream, and would be able to attack those active pumps. Suppose you don't follow this meal time dependency pattern, then there is a significant chance that the PPIs may become ineffective. Apart from it, 50% of the patients still experience symptoms 3 days after treatment, which means they are disappointed. 50% of the people, half of the people are disappointed even after the use of PPIs for 3 days. And apart from it, 40 to 70% of patients with GERD experience nocturnal acid breakthrough, about which the next two speakers will talk a lot. And next slide, please. GERD management also has significant challenges. With such a suboptimal control of acid, you can clearly say that 2/3 of the patients have insufficient relief of their symptoms after their first PPI dose. Again, this is a repetition. 50% of the patients continue to experience symptoms even after 3 days of treatment. And henceforth, given that you have a lot of challenges with PPI, we are looking out for a better molecule. Now, apart from the pharmacological barriers to optimal acid control, I'm repeating the problems again. PPIs have been the drugs to go for last 3 decades, but we had been using it with a lot of challenges. One is its delayed onset, genetic influence. Next slide, please. Next slide, please. Poor nighttime effectiveness, stability challenges, which I have not discussed. The most important thing is that PPIs or prodrugs, they have to be activated. For them to be activated, they need an acid environment. But again, having been activated, they are unstable in an acid environment. So they can easily get destroyed, and henceforth they have challenges with their stability, and they are dependent on meals. So given so much of challenges, you should now be thinking, why haven't we got a better molecule? But now, the last few months, we have got a better molecule in form of PCABs, which are currently available. All we know is that up to 30% of patients can have non-responsive GERD. The various causes of non-responsiveness is that they may be treatment non-adherent, or they may have weak acid reflux on which the acid suppression may not work. They may have residual acid, they may have nocturnal acid breakthrough, or due to acid pockets, or due to functional esophageal disorders. So with so much of issues happening with the PPIs, it is good that we are looking out with newer molecules, and about which the next two speakers will talk to us about how they have evolved and how better they are with the current treatment available. Thank you.
Thank you, Dr. Hariharan. So, Dr. Karthik, would you like me to continue projecting this slide deck, or would you like to share your own slide deck? All right, sir. Over to you, Dr. Karthik.
If you look at a comparison between PPI and PCAB, I think this is predominantly what the context setting was. The PPI requires a conversion from to a reactive form on acid exposure, and it causes an irreversible binding to the external surface of the acid pump. Whereas if you look at the PCABs, they directly bind to the potassium binding domain, at the resting and stimulated state, and they don't need to stimulate the proton pumps. They are able to inhibit new proton pumps as well, and it causes a very fast inhibition, very stable inhibition, and the time to maximal concentration, unlike PPIs, which takes 4 to 5 days because of the T half cycle, as well as because of inhibiting active and inactive pumps. The inability for the inactive pumps is definitely shorter. So it's just a day. Next slide, please. So if you look at the drug profile, Tegoprazan is a potassium-competitive acid blocker, like was mentioned at the beginning. It was launched in Korea, and it's now made its way to India, and we've been very successfully using it with good results. The indication and dosage and administration, as mentioned by the Koreans, was for GERD, they give 50 milligram once a day for 4 weeks. For those patients who do not heal or have persistent symptoms after 4 weeks, they recommend an additional 4 weeks. For any RD or non-erosive reflux, it's just 4 weeks once a day. For gastric ulcer, you give it for 8 weeks. And for eradication of H. pylori therapy, you give the Tegoprazan, clarithromycin, and amoxicillin combination at 50 milligram, 500 milligram, and 1 gram respectively, but twice a day for 7 days. And for the maintenance of GERD, they recommend the 25 milligram once daily use. Now, that dose, I think we are still yet to get. Next slide, please. So it delivers a very rapid, fast symptom control within 30 minutes. So this actually is very good for, if you look at on-demand therapy, this is something that is an unmet need. So it's something that is very good. So if you look at a multi-center trial which was performed, evaluating on-demand Tegoprazan versus esomeprazole in GERD patients, it showed that there was a significant response to Tegoprazan as opposed to esomeprazole. Apologies. And this relief was checked every 30 minutes, and the release was sustained for up to 3 hours. Next slide, please. So Tegoprazan shows faster control as compared to other acid blockers. So if you have to give it for an on-demand therapy, you want it to act really quickly. So if you look at Tegoprazan as compared to the other potassium-competitive acid blockers or proton pump inhibitors, an intragastric pH of 4 is achieved within just half an hour of administration of Tegoprazan. And we'll see in the later slides that it's irrespective of the meals as well. Next slide, please. So what GERD predominantly consists of. So if you look at the survey done in India in 2017, 7.6% of the patients actually have, so that's the rate in India of proportion who have GERD. Predominantly, heartburn is a major symptom. So we want a rapid relief in this. And we have noticed even in the NERD group, in the non-erosive group, heartburn is a predominant symptom or a major symptom of reflux. So you want something that works really well for that. And Tegoprazan has shown superior efficacy over placebo in achieving heartburn relief right from day one itself. Next slide. So if you compare Tegoprazan versus esomeprazole for NAB, that's nocturnal acid breakthrough, which translates to nighttime heartburn and sleep quality. The time to first nighttime heartburn-free interval was shorter for Tegoprazan as compared to esomeprazole. So it's like 1.5 days versus 3 days, and that was found to be significant. If you look at the, there was a significant more patients receiving Tegoprazan who achieved complete resolution as opposed to esomeprazole as well. And this was also studied. So if you look at the consistent 24-hour control for overcoming nocturnal acid breakthrough, if you look at PPI, we know that we have been administering it twice a day. There are formulations of higher strength so that you can overcome the nocturnal acid breakthrough. And despite that, patients do complain of it. But whereas Tegoprazan exhibits a sustained control of the intragastric acidity for a 24-hour period. Next slide. So it produces a more rapid, potent, as well as sustained nighttime acid suppression when administered at night. So if you look at the time after dosing, like we saw, the peak within 4 hours is the blue curve of Tegoprazan. If you look at the pH above 4, it's sustained throughout the time duration, especially if you give it at night. You won't have to worry about the nocturnal acid breakthrough. Next slide. Something very important for the pharmacokinetic profile is that it is similar whether you give it with food or without food. So it was studied in the fasting 30 minutes before as well as 30 minutes after. And the area under the curve level was similar in all the 3 scenarios. And I'm sure even if you take it with food, it really doesn't matter. Next slide. The phase 3 trial, which we spoke about, that has been approved in USA and it's going on in other countries as well. This is the primary endpoint, was the percentage of patients with complete healing by week 8, and they looked at secondary outcomes, which was 24-hour heartburn-free days, percentage of LA, C, and D with complete healing, as well as week 2 and 8. They checked for all patients complete healing at week 8 as well as complete healing at week 2. So they included all LA A grade, Los Angeles A to D for erosive esophagitis, and they found that Tegoprazan proves to be faster acting and a more effective drug than a proton pump inhibitor for the healing of erosive esophagitis. It met all the primary endpoints as well as the secondary endpoints for healing phase. And there was superiority as compared to lansoprazole at 2 weeks and 8 weeks. I'll show you the slide subsequently. Of course, the dosage that they mention is 15 milligrams. In India, we use a higher dosing, but I think for quicker dosing, definitely it helps. It met all the primary and secondary endpoints, and the safety and tolerability was similar to placebo as well as lansoprazole, and the mean serum gastrin levels remained within the range. Next. So if you look at the symptom control and heartburn-free days with Tegoprazan, this is again part of the phase 3 study only. The complete endoscopic healing at week 24 was assessed. Tegoprazan was definitely superior as compared to 15 milligram once daily of lansoprazole. Next slide. Again, in percentage of heartburn-free days at a 6-month period, Tegoprazan demonstrated superiority and improved the heartburn-free days. Next. So just a summary of the previously mentioned data was that whether you're looking at GERD, when they compared Tegoprazan and esomeprazole, Tegoprazan demonstrated great efficacy, whether it was NERD, gastric ulcer, as well as maintenance of healed erosive GERD. Next slide. So this is the Korean phase 3 study, wherein if you look, it was Tegoprazan was compared to esomeprazole, and it showed higher rates of healing of erosive esophagitis. Next slide. Again, the phase 3 double-blind study, which showed at 50 milligrams as well as 100 milligrams, it showed superior therapeutic efficacy compared to placebo, as well as a favorable safety profile. Next slide. The same applied to gastric ulcer as well. It was not inferior to 30 milligrams once daily of lansoprazole. They compared it at the 50 milligram and the 100 milligram dose. Next. This is in erosive esophagitis for the maintenance. Here, the 25 milligram Tegoprazan arm was shown to be non-inferior to 15 milligrams of lansoprazole, both in terms of maintenance rates of remission at endoscopy at 12 weeks as well as 24 weeks. And this is the study design which they followed for the phase 3 study. Results will follow. Next, please. They compared Tegoprazan and esomeprazole, and if you look at the cumulative endoscopic healing rate for erosive esophagitis at week 8, they did a FAST, which is a full analysis set. This is 241 patients, and they found it to be non-inferior to esomeprazole for erosive esophagitis healing at week 8. Next. The secondary endpoint, which was cumulative endoscopic healing rate for erosive esophagitis by week 4, that also was comparable. In fact, it showed superiority. This, however, was a non-inferiority design. Next slide. So this is something that's important, which is that it's a powerful alternative to overcoming H. pylori therapy. I think the PCABs, the trump card for a PCAB is the rapidity of onset of action and what we mainly need it for, which is a major cause of dyspepsia in our country, at least, which is H. pylori. We have a lot of problems with our H. pylori cure rate, with the resistance of molecules, and I think with the CYP, metabolism patterns, which Dr. Hariharan sir spoke about also previously, the fact that this is independent is very important. Secondly, we are also seeing in patients infected with clarithromycin-resistant H. pylori strains, Tegoprazan actually demonstrated a markedly superior eradication efficacy as compared to the PPIs. Now, that was confirmed through genetic sequencing as well as culture-based MIC testing. What actually happens, to summarize, is basically Tegoprazan maintains a pH of above 6 persistently when you give it, and it's very rapid. In H. pylori, we give a very short course for 7, 10, or 14 days as is studied. And for clarithromycin to work at the 23S rRNA gene of the bacteria which it binds to, the level of the pH should be above 6 and it should be maintained so right at the time when it's acting. And that is with Tegoprazan, it's maintained very, very well. Whereas if you compare that with PPIs, the sustained maintenance of a pH of above 6 is not maintained. And hence, you do see clarithromycin resistance to a very high degree, and that leads to us using alternative regimens or not very comfortable prescriptions aren't ensured, etc. Next. So Tegoprazan-based regimens deliver superior H. pylori eradication rates, whether you look at the Tegoprazan quadruple regimen or the dual regimen with amoxicillin or the standard quadruple regimen. Tegoprazan-based dual as well as quadruple therapies achieve higher eradication rates. And I think when you're looking to the tune of 10%, it significantly matters in our practice that this will be more useful. Next. So why does Tegoprazan outperform PPIs? This is just a clinical comparison. I think it's like a summary of what we have said previously. So the time to achieve an intragastric pH of more than 4 is just 30 minutes, whereas it's 4 hours for the other molecules. It holds the pH for a value of more than 4 for a longer period of time. The CYP-based drug interactions are CYP3A4 over here, whereas for pantoprazole, rabeprazole, esomeprazole, if you look at, they interfere with the CYP2, C119, C19 as well. And hence, even when you're giving it with antiplatelets, you have to give it with caution. You have to look at whether the drug is performing well, how long to give it, and whether you can give it for double dosing or not. And the maximal inhibitory concentrations are right from day 1 as well. So in short, it delivers faster onset, stronger and more sustained acid suppression, and a cleaner interaction profile, and thus making it a clear superior molecule. Next slide, please. So the strengths, to summarize, is that it achieves faster control because of the pH of more than 4 within half an hour to 1 hour. Nighttime acid control or nocturnal acid breakthrough will be less. No effect on food, so a very good pharmacokinetic profile, whether you take it before or after meal or an empty stomach. Optimal pharmacodynamic for successful H. pylori eradication, and a low drug-to-drug interaction potential because it's not affected by the CYP2, C19 pathway. So no interaction potentially with clopidogrel, statins, and tacrolimus. And with that, I'd like to end my talk. Thank you so much again for the opportunity.
Thank you, Dr. Karthik, for taking us through such an elaborate discussion on Tegoprazan. Now, I would like to request Dr. Kiran Shinde to kindly start this presentation. Dr. Kiran, would you like me to project, or would you be projecting your own slides?
You can do it, you ma'am. No problem.
All right, Dr. Kiran, over to you.
Yeah. Very good evening, all of you. Excellent talk by Hariharan sir and Dr. Karthik. Further, I will proceed my talk. the Tegoprazan in perspective, let's see the safety profile, guideline context, and comparison with other potassium-competitive acid blockers. So, as we know, we should know the safety profile, drug-to-drug interaction, along with the other present group and other PPI. So, especially CKD, cardiac patients, and cerebrovascular accidents. These are very important thing in most of the our clinical practice in gastroenterology. So, let's see. So, about the Tegoprazan, minimal CYP influence, and it is a reliable across all CYP2C 19 phenotypes. As we know, it is mainly metabolized by CYP3A4, no inhibition or induction, and it is rarely affected by CYP2C 119. So, mean nighttime percentage of time to maintaining the pH equal or more than 4 is good with the Tegoprazan according to the this phenotype. So, nighttime suppression, nighttime acid suppression, Tegoprazan was not dependent on CYP2C 19 phenotype. Next slide, please. So, it has very clean drug to drug interaction profile, no interaction with atorvastatin. So, as we know, it is metabolized by CYP3A4. It is not a potential inhibitor or inducer like atorvastatin. So, vonoprazan inhibitor potential on CYP3A4 as well fexoprazan. So, in 24-hour study, so tegoprazan did not affect the plasma concentration or of atorvastatin drug, unlike vonoprazan. Next slide, please. So let's see the serum gastrin level with the tegoprazan. So hypergastrinemia was observed when atorvastatin co-administered with vonoprazan, but hypergastrinemia incidence increased after multiple doses of atorvastatin co-administered with vonoprazan, but it is not observed with the uh, tegoprazan group. Next slide, please. So, safe with clarithromycin. Already Dr. Karthikeyan highlighted these points. So, no drug-to-drug interaction concern. So, as we know, the clarithromycin resistant cases, it is a drug of choice. It is a more, it is not a potential inhibitor or inducer, clarithromycin. So, unlike other PCAB, it has safety profile with the clarithromycin resistant in H. pylori eradication. Next slide, please. So it is a powerful alternative in overcoming H. pylori therapy, clarithromycin resistant. Dr. Karthik already discussed about the resistant was confirmed, the mutation and all. So the USA already in Trump PS study, the tegoprazan in maintenance of erosive esophagitis. So 50 milligram OD dose comparison with the lansoprazole 15 milligram OD dose. So uh, serum gastrin level they have compared, and so efficacy and safety result support tegoprazan as a clinically meaningful alternative to PPI in maintenance erosive esophagitis healing, especially in severe grade of the esophagitis. So most of the studies shows it will heal completely 6 to 8 weeks therapy. So let's see the cardiac drug profile, especially in scenario like dual antiplatelet drugs, post angioplasty and all. So retrospective cohort study um, receiving DPT therapy, the cumulative incidence of major bleeding was 31% lower with the TIGO. So Korean nationwide health insurance database. So comparison with PPI, the incidence of GI bleeding reduced 28% lower with the TIGO, and minimal adverse cardiac and cerebrovascular events 14% lower. Myocardial infarction was 17% lower. And very good thing is that stroke also 5% lower incidence rates, along with the intracranial hemorrhage 38% lower. So it demonstrated cumulative GI and major bleeding risk without increasing cumulative ischemic events in the cardiac and stroke patients especially. Next slide, please. And along with the dual antiplatelet drug patients. So also additional advantage compared with the other Prezone group. So fewer liver-related adverse events with the Tegoprazan. So let's see during the maintenance therapy. Uh, these are very safe drug, but few patients may feel like cough or dizziness or sometimes uh, nasopharyngitis kind of things. But alanine aminotransferase increased and gastrin and gamma GGT level increased. It has observed in Tegoprazan 25 mg group compared with the lansoprazole group. It has the safety profile. Especially like CKD patient, high creatinine patients. So low risk of renal function deterioration compared to the other PPA. Because in CKD patients, like Dr. Karthikeyan shown the last few slides, that like along with the atorvastatin, clarithromycin scenario, especially cardiac drugs also I discussed like dual antiplatelet drug scenario. Like post transplant, liver transplant and post renal transplant, most of the times we'll get a reference, and most of the patients are along with the tacrolimus immunosuppression drug. So with that, Tegoprazan has very safety and good profile. So with this long-term follow-up, as per the database studies, there is a low risk of renal dysfunction deterioration compared to PPI. Next slide, please. Especially patient at risk of CKD progression. So creatinine doubling rate and risk of kidney dysfunction, it has very good safety profile compared to other PPI. Almost they said 48% decreased risk with the PCAB drugs. Next slide, please. Also, it has 27% lower incidence of cumulative hepatotoxicity compared to all other 6 PPI combined together. Next slide, please. So they compared the primary endpoints, hepatotoxicity compared with the other PPI drugs. 39% lower with the pantoprazole and lansoprazole, almost 30% lower dexlansoprazole, 20% lower risk observed comparison with the rabeprazole, and 19% with the comparison with the esomeprazole. So most of the GERD consensus, it is a recommended first line drug, and these are the PCAB drugs: potassium-competitive acid blockers, erosive reflux esophagitis, Barrett's esophagus, and also non-erosive reflux disease. Next slide, please. So as we know, the maintaining of the pH superiority more than 4, equal to 4 or more than almost 4 pH, good potential effect of the PCAF, and fast action, rapid onset of action. So these are also global guideline endorsement. Mexico and China led the shift. So Chinese expert consensus statement is both PPI and PCAF are priority therapy for the GERD. Next slide, please. So let's see comparison with the other Prezone group. So what are the advantage? Because other compare with the vonoprazan and fexoprazan. So as we know, the Tegoprazan has fast control. The pH maintaining more than 4 is almost 0.52 in 1 hour. Compared to vonoprazan, it is a 4 hours, and fexoprazan, it is also similar. So also other 24-hour pH holding capacity almost similar with the other Prezone group. Additional other advantage is influence on CYP 3A4. So it is not a potential inhibitor, so or inducer. So it has additional effect like drug-to-drug interaction, drug interaction, especially atorvastatin no effect, clarithromycin resistant H. pylori eradication. It is a good drug, and other like tacrolimus and dual antiplatelet drug. It has good safety profile with the other Prezone group compare. The Tegoprazan has good advantage. Indication almost similar. Next slide, please. So sustained acid suppression is more clinically relevant than pharmacokinetic parameters like half-life. So as we know, the Tegoprazan short half-life is not a limitation when compared to the other Prazan and PPI. So pharmacokinetics versus pharmacodynamics. So as we know, half-life is to how to long the drug stays in plasma, so which doesn't necessarily translate into efficacy because it has short plasma life, only 3 to 5 hours, but its pharmacodynamic effect, that is acid suppression, lasts more than 24 hours. So that is a very big advantage. And 24-hour pH holding time more than 4 for Tegoprazan is almost 65%. Next slide, please. Okay. Thank you very much for the hearing and giving me the good opportunity. Thank you.
And thank you, Dr. Kiran Shinde, for taking us through the Tegoprazan safety aspects as well as the guideline aspects of using Tegoprazan. So now I would stop sharing. So as we have nearly 100 participants who were there following the updates given by Dr. Hariharan as well as Dr. Kiran and Dr. Karthik. So a couple of questions were put forward by the audience. So I will put forward the questions. Dr. Hariharan, am I audible? Yeah, yeah. So going ahead with the first one. So one of the doctors has put forward this question: how effective is Tegoprazan in the management of upper GI bleeding, including the post-TSD and post-EVL bleeding? And also, can it be considered as a potential alternative to intravenous PPIs in these kind of settings? So over to you, sir.
Vonoprazan in upper GI bleed. We haven't got direct studies of Tegoprazan in upper GI bleed. But having said that, we are translating whatever effect of Vonoprazan could do. If Tegoprazan could do even better, then the effects do translate in the same way, in a slightly better way as well. Clearly, the PCABs have been highlighted for use in upper GI bleed. They are found to be as good as the PPIs, which are given continuously by IV. My personal experience also is there that in cases of upper GI bleed, and I have started using oral PCABs twice a day for first 3 days, and they appear to be extremely effective. Regarding the effect of PCABs on the post-ESD bleed and other conditions, they are very effective in such conditions in managing the post-ESD bleeds. In fact, compared to PPIs, there are quite a few studies where they have compared the PCABs to the PPIs, where the PCABs have scored over the PPIs in terms of reducing the number of bleeds following major GI interventions like ESD. Yeah.
Definitely, the PCABs are superior to PPI. In fact, one of the major adaptation of or the increase in the use of PCABs came from the Japanese as well as the Korean data that it can completely prevent bleeding, and even in the absence of closure of large defects post ESD. And I think that was the first strong data that came from the East. Of course, now when we see lesions where endoscopic therapy has been done, after the initial, in our institute at least, we are still using proton pump inhibitor infusion to begin with. And because we want to clear the field, we keep the patient empty stomach as well. But after endoscopic therapy, we have started using PCABs, and we have got very good result for it. I have seen data of the same for variceal bleed. Actually, PPI, initially it was told either you use a PPI or you use the sucralfate containing gels. And now we know that the recent publication in American Journal of Gastroenterology from the PGI group showed that PPI use was actually beneficial. So I'm sure the same would correlate for tegoprazan as well because of better acid suppression.
So already Dr. Karthik discussed the good point, valid point, and so we are also in our centers we are using traditional PPI like esomeprazole or omeprazole infusion, PPI infusion, initial days. So the same thing, the because blood clots, bleeding, and all. Acute phase, yes, traditional PPIs has good enough data, so we are using that only. But yes, once patient stable, we can shift to the Tegoprazan once patient optimized, like grade C, grade D esophagitis, even post-tibial ulcer bleed. That Tegoprazan will be effective definitely.
Thank you, sir. There's another one regarding the H. pylori eradication therapy. So, what would be the most appropriate or ideal combination regimen to use in India alongside Tegoprazan 50 milligram twice daily? Over to you, Dr. Hariharan.
Okay, the pH goes above 4 within half an hour. So which means on day 1 you are getting a best acid suppression. So what is that best acid suppression means? One, it lends stability to the antibiotics. Number two, once the acid gets suppressed, the H. pylori are able to come out and proliferate, and there our antibiotics goes and hits them. Suppose the PPIs are going to take 5 days for optimal acid suppression. Whatever antibiotics you are giving in the first 5 days will really be not of much use because the acid suppression is inadequate. Whereas from day 1, you're having a drug which is giving you a fantastic acid suppression, which means that H. pylori are going to come out and proliferate, and our antibiotics are going to act. So any antibiotic regimen along with the PCABs are always much better than the PPIs with antibiotics. This has been clearly proven in various studies. In fact, if you look at the optimal, the maximal HP eradication with PPIs and antibiotics have been close to 75, 80, or in the best case scenario up to 85%. Whereas with PPIs and with PCABs and antibiotics, the H. pylori eradication has been more fantastic, going beyond 93 to 95%. Again, having discussed about that, number two, we have clarithromycin resistance in our country. Along with it, we also have metronidazole resistance. So we have lost two very nice antibiotics. However, antibiotic amoxicillin is still available. It has not shown that significant level of resistance to H. So one of the best regimens that I would always think about is to use the PCABs with amoxicillin up to 3 grams per day would be what I think is the best regimen, and the studies have shown eradication rate up to 95% in studies. So that is what I would prefer to use. Although there was one slide where Karthik projected where you clearly shown that tegoprazan based quadruple therapy or tegoprazan dual therapy, which is tegoprazan and amoxicillin, both were superior to standard quadruple therapy with PPIs or standard dual therapies with PPIs. So in either way, whether you're going to use dual or quadruple with PCABs, they are definitely far superior to therapies with PPI, and they are the best. As far as my this thing is done, now since the PCABs have come in, I have started using only PCABs based HP eradication therapy, which I find it are extremely superior to PPI based eradication regimes.
Thank you so much, Dr. Hariharan. This will help a lot of people who are practicing, who are using this drug in the H. pylori management. And for the betterment of the patients, these inputs that you have provided are really helpful. So, we do not have much time, sir, I would like to put forward some more questions which the audience have asked so that we can quickly cover up those as well. So, we would like to, the point of view of Dr. Hariharan, Dr. Kiran, as well as Dr. Karthik, wherever you want to just add to the points. So, one of these is despite the potent acid suppression by Tegoprazan, why has Tegoprazan not demonstrated clinically significant hypergastrinemia? This is one of the queries put forward.
No, if it has not, it hasn't. But why is it that you expect that there should be a hypergastrinemia? It is not necessary. Fundamentally, the increased level of gastrin, apparently on the initial studies, they showed that there was a slight peaking up of gastrin, and then it flattened out to a certain level. Whereas with PPIs, again, the comparative levels between the PPIs and the PCAB, particular Tegoprazan was done. With Tegoprazan, the level of rise of gastrin was much less than PPIs, which I find it to be good for us. And why that has not happened, I cannot fundamentally answer that question, but I have no answers unless otherwise Karthik or Kiran has any answers to why the gastrin level doesn't go up with PCABs. I don't know. Karthik? I tried checking why it doesn't go up. But there's Yeah, there is initial rise, but then it plateaus off. But whereas with PPA also there is a progressive rise, but then when the level of rise of gastrin between PPIs and PCABs, particularly tegoprazan, is much the same. I take it as an advantage, but I can't question why it doesn't go up. But I have never bothered to find out why it doesn't go up. But if people are thinking that the rise of gastrin is directly related to the acid suppression, I think there should be a way to find out. But at this moment, I don't have an answer.
So there are few studies means Tegoprazan with atorvastatin in that some 2021 I think some pharmacology publication is there in 2021 I think. So they mention compare with the other Prazon, the superiority of the Tegoprazan is high because regarding the serum gastrin concern. So but don't know why how they yeah. So
So even in the literature, only the hypotheses are put forward. There is no mechanism which is elucidated for the uh, no hypergastrinemia happening. So there's another one. This is a tricky one. In patients with functional dyspepsia, can tegoprazan be considered as a therapeutic option for the epigastric pain syndrome subgroup? In functional dyspepsia, can tegoprazan be considered as a therapeutic option for the epigastric pain syndrome in patients? Thank you, sir. A few more questions. I'll take one or two because we are running short of time. So, for gastric ulcer management, what is the approved dose of Tegoprazan and what is the recommended duration of therapy? You've already.
Oh, this is for you're talking about H. pylori. Gastric ulcer, the Korean data is 50 milligram once a day for 8 weeks.
All right, sir. So another big question someone has posted: Tegoprazan appears to achieve rapid acid control compared with other PCABs. What pharmacological characteristics contribute to this rapid onset and efficacy of Tegoprazan?
Of its unique chemical structure, that it may be the reason why it is fast tracked, because they are all chemical molecules, isn't it? So it's based on their chemistry. Otherwise, I wouldn't have anything else to say why it acts faster. But certainly, when it acts faster, I take that as an advantage.
So, Dr. Kiran and Dr. Karthik, would you also like to add some points to this?
Yeah, so I think, what Sir said essentially is the molecule is like that, so it's a superior molecule. I think that's the only why. The why goes down to the pharmacokinetic and the pharmacodynamic pathway. So it's just a superior molecule. You have to face it. That's all. You can't really go into the depth of why does it do that. It does. If you want to know the real why, it's probably the pharmacokinetic and pharmacodynamics. I think beyond that, there is no other explanation to it.
Yeah, they are all based on the chemistry of the molecule,
Yes,
isn't it?
the
The
biochemical stuff.
pharmacokinetics and PK and PD are dependent on the chemistry of the molecule. So based on the chemistry, you just take one molecule, you just break the side chain and put something else in, another molecule comes in. That's how different groups of molecules comes in.
Yes, sir. So stability in the pH also is enhanced in this case. Just like in PPIs, we require the enteric coating and all. So Tegoprazan doesn't require that enteric coating. So definitely.
That's a special property of PCABs because we don't need it. It's not a pro molecule, and it is already an active molecule, goes and acts directly. It doesn't require an acid medium to get activated. Plus, the thing is that it's quite stable. Unlike PPAs, once activated, it becomes unstable.
Yes, sir. So, Dr. Hariharan, thank you so much for such important insights on so many aspects of Tegoprazan. So, sir, I would request you to give the closing remarks as we have come to the end of the meeting.
Okay. Thank you very much, Dr. Bushra. And it was one of my thanks to Dr. Reddy's for organizing this evening CME, which was quite nice. We had wonderful talks by Dr. Karthik and Dr. Kiran. Karthik nicely put across the various aspects of Tegoprazan, various studies. In fact, some of the studies which have been quite recent. Most of you would have understood that by the time that I was whining why, although we had PPIs for 30 odd years, we continued to use it despite its flaws because we didn't have anything else. Afterwards, then Karthik put across that we have PCABs now, which he said clearly that why they are superior, how they are superior, and he also you showed through various studies about the superiority in its acid suppression, its use in erosive esophagitis, and its use in H. pylori. And next, Dr. Kiran put it very nicely, spoke about the safety aspects. It is not that you got a powerful molecule, you got a very sharp knife, it is also safe to use it. It is extremely safe, how good it is. We also got excellent data. And the most important thing is that constantly we are worried. When it comes to PPIs and the cardiac patients, they constantly worry about, is this going to affect the metabolism, like clopidogrel metabolism where it is an issue, in which case whether he is going to get a chance of getting a heart attack and other things. But then this was all clearly shown that PCABs, particularly Tegoprazan, doesn't have any effect on the metabolism, which makes it extremely safe for all sorts of cardiac patients. Apart from it, there was one thing, we have three PCABs. One is the fixoprazan, vonoprazan, and now we are talking about Tegoprazan. Whereas the first two, they have a potential interaction with atorvastatin, which is quite commonly used, whereas this does not have one, because it's not neither a COIP 3A4 inducer or inhibitor. So that way, by drug interaction wise also, you have a better profile with Tegoprazan. Given all this, so you had first discussed about unmet needs, then Karthik spoke about the PCAB, and then we have a very, very safe molecule. So we have overall got a wonderful molecule for use in the future, and effectively that this is a good molecule for even H. pylori eradication, which is widespread in our country. So overall, you've got a fantastic new molecule in the name of PCAB, which is the third PCAB to come into the Indian market, and we are all excited to use it more and more with more things like we are looking forward to use it in the acute GI bleeds. My experience with use in acute GI bleeds is small, but I do find it very beneficial, and henceforth over the future we will find more avenues of use for these PCABs in various GI conditions. With this, I would like to close the evening meeting, thanking the Reddy Labs again for the opportunity. Thank you very much.
Dr. Hariharan, thank you so much for the closing remarks, but I would like to add some point here. Although the closing remarks have already been mentioned by you, but one question which has been asked again and again by many participants. So can I ask that question? Thank you so much, sir. So there is a question regarding co-usage of PCABs and sodium alginate together.
Thing is that why alginates continue to be, the property of alginates is only to form a raft and prevent the reflux of contents back. PCABs help in suppressing the acid. When PCABs suppress the acid, it changes the quality and sometimes to a reasonable extent the quantity of acid reflux. Whereas alginates or rafts, they prevent physically the contents of gastric contents going back into the esophagus. So there is absolutely no contraindication, nowhere so that both should not be used together. They can be used together without any hesitation.
Yes.
So really happy to see the conviction, and thank you so much. I mean, the ideas as well as the practical insights received from all the eminent doctors present here will definitely help guide the practice of so many people who look up to you. And thank you so much. Santosh, would you like to?
No, thank you, sir. Thanks a lot. Thanks to Dr. Hariharan. Thanks to Dr. Karthik, sir. Thanks, Dr. Kiran, sir. Thank you.
Okay, thank you so much.
Thank you, sir.
Thanks for joining, all of you. Good night.
Something which creates a barrier between us and the environment or explosives, I think that should be the first place to start.
Yeah, that's true. Especially in Bombay.
Bombay, Delhi, anywhere.
Correct, that's true.
Anywhere in India.
So that was a very interesting discussion. We'll move on to our next segment, which is some of the most searched questions by dermatologists online. So we will attempt to answer questions one by one, and we'll just go around.
Yeah, absolutely.
So I'll start with the first one, which is saying that are non-comedogenic emollients safe for acne-prone skin, and how to counsel patients? Well, Yes, definitely. They are extremely safe for acne-prone skin. Non-comedogenic means that it's not going to trigger your acne. So that's the way you kind of counsel them, saying that it has ingredients that will in fact support your acne recovery and also support the retinoid therapy, because usually patients who have acne, they're on all kinds of retinoids, maybe oral or topical, which tend to dry out the skin. So here I feel like the moisturizer that you're using plays a huge role in the outcome of the patient, like how comfortable their journey is going to be using the therapy that you're giving them. So yes.
Good. I'll go next. So I'll do the second one.
Yes. We can all open the one that you're opening. Yes.
Perfect. So the role of emollients during isotretinoin therapy, dosing, timing, and formulation. Do I have to answer this? I thought we had a great discussion on this. But anyways, the role of emollients, definitely, I would go one step ahead and say not only emollients, but a complete moisturizer when you're prescribing isotretinoin. See, isotretinoin for us it's something Rixon's taken, I've taken, I don't know if you've taken it, but isotretinoin is something which...
Definitely I have.
Yeah, exactly. And it's something which we prescribe on a daily basis. And it has that dreaded side effect, which is actually a therapeutic side effect, which is chylitis and xerosis. So you would want to preempt the barrier rather than repair it once it's damaged. So preempt the barrier from the first day when I start patients on isotretinoin, even before the purging or the flare starts, they're already on a good moisturizer, which will repair their barrier. And even barrier repair moisturizers without isotretinoin have a role to play in acne. Acne also is barrier dysfunction, and back in the day, and if you see Western patients even today, it's called acne rosacea, because acne patients are more prone to sensitivity and redness, which we see a lot now. So yeah, no questions about it. 100%.
Sometimes not taking care of that is the reason why patients stop therapy sometimes. Like,
Absolutely.
they just go off medication because,
Absolutely.
They can't tolerate. Go with the next one. Can concurrent emollient use reduce retinoid and benzoyl peroxide induced irritation? Of course. I mean, this is something, in fact, if occasionally if I find the skin, a person has very sensitive skin, I would actually recommend for the first week, just use like a cleanser, moisturizer and sunscreen, and initiate your topical retinoid and benzoyl peroxide maybe after 5 to 7 days. So you stabilize the skin before you go in for comedrolytic therapy. So yes, it's very important. I think you can start before and continue concomitantly, and even between applications, if you give alternate day applications, you can just recommend them to apply emollient on the days that they're skipping the retinoid and benzoyl peroxide.
Do antihistamine-treated urticaria patients benefit from adjuvant emollient use? Definitely. I think the answer is a strong yes, because even though urticaria is not primarily coming from barrier dysfunction is definitely present, and these patients are constantly uncomfortable. I think that itch is something that is making their life hell. So a good emollient which is soothing the skin, it does half the job, because the patient really feels calm, and I think that's what is going to make the patient happy at the end of the day. So yes, definitely.
Yeah. And I think even those who have dermographism,
Yes.
Because if their skin is dry and they end up scratching, they'll get those wheals. But if the barrier is intact and they'll feel less itchy, they'll tend to create less rashes.
Correct. You used a wonderful phrase, sensory threshold, right? At least
Yes,
you're increasing the sensory threshold
absolutely.
with the barrier repair moisturizer. Okay. Do antihistamine treated urticaria patients benefit from adjuvant?
Next one.
Oh yeah, sorry. I thought so. Is skin barrier dysfunction a pathophysiological driver in chronic spontaneous urticaria? Definitely. I think we spoke about the same thing. That it's not a primary driver, where barrier dysfunction is not something like atopic dermatitis is barrier dysfunction leading to inflammation.
Yes.
But in CSU, it starts with itching, it starts with the mast cells, everything centers around the mast cells and histamine. But in the end, barrier repair does have a role to play even in our urticaria patients, for sure.
Yeah. And I think in chronic spontaneous urticaria, the mast cells are already sensitized and they're ready to explode and release. You just need one physical trigger to start that process. Okay, the next one. How does barrier impairment in urticaria differ from eczema shared treatment strategy? Okay, so in eczema, like just Aseem just mentioned, in eczema, barrier dysfunction is a primary problem, and that's what leads to an eczema. Whereas in urticaria, it may be a secondary thing that happens. Mast cell degranulation leading to inflammation could, so inflammation precedes the barrier dysfunction, whereas in eczema, the barrier dysfunction precedes the inflammation.
True. Yeah, absolutely.
How does barrier
combine
how to combine emollients with topical corticosteroids, sequence, timing, and rationale? So I think
That's a tough question.
Yeah, I think any patient who requires a steroid definitely requires a moisturizer as well. And people may argue about which goes first, but what I personally do is that steroid goes on first on the affected area. You can wait like a minute or two and then apply the moisturizer on top is what I recommend. And moisturize probably 3 to 4 times a day if possible, but usually patients are a little bit lazy, so twice a day is something that I stress upon. Ideally, I think it would be best if we could wait half an hour and then put the moisturizer on, but usually patients will not wait that long. So what's more important is that they put on the moisturizer. So I tell them wait a minute and then put it on. So that's what I do. If you differ, you can.
No, so this is a question which I think my HOD used to say in dermatology, if two people have to disagree with each other, dermatology is the best branch. You can get the same outcome from 2 different diagnoses, different treatment plans, completely different procedures or clinical management. But so the point in question is when you apply a steroid first, because it goes through the thick of a psoriasis plaque, it goes through the fissures of the plaque, it should be absorbed better. But common knowledge tells us if the barrier is better, the steroid will get absorbed much better. So I think this is a
moisturizer first.
Yeah, it's a chicken or egg question. I think there's no answer.
I think the rationale behind using an emollient first followed by a steroid is because the emollient also has penetration enhancer. So,
Correct. The barrier
so
becomes
the
better.
steroid penetrates better. And if you apply the steroid first and then you immediately apply an emollient, there is in that whole process of application of emollient,
Spread too.
perilesional, yeah. So perilesional side
you can
effects
do
is
the
what
steroid
people are,
and
yeah.
perilesional.
If you immediately apply, so like you said, apply it, leave it on for half an hour, the steroid, and then apply the emollient. So by then, most of the steroid absorption will happen, so less chances of a perilesion.
Correct, but in the real world, then it's only the steroid.
Yeah.
Correct, exactly. And sometimes what I do is, I may,
It's okay.
people may disagree, but sometimes if
Casual
a
chat.
patient is just applying